So we're going to finish now with a presentation by Dr. Ernie Hawk. And Dr. Hawk is a great addition to our team. He's the president and division head for cancer prevention and population sciences at the University of Texas, MD Anderson Cancer Center. Dr. Hawk's been involved in chemoprevention research focused on non-steroidal anti-inflammatory drugs and COX-2 inhibitors. And he has earned numerous awards, including the NCI Research Award for Distinguished Achievement in Cancer Prevention. Dr. Hawk currently serves as the Senior Editor for Cancer Epidemiology, Biomarkers, and Prevention, and Deputy Editor for Cancer Prevention Research. He earned his medical degree at Wayne State University and his Master of Public Health degree at Johns Hopkins University. So we're very happy to have Ernie involved in this work, and we look forward to his comments.
Thank you, Steve. Thank you, Steve. I came at this less from the perspective of a critique of the papers and more as an eager learner, because with regard to the first paper, that by Dr. Warnecke and his colleagues, I think we're facing a very similar situation in Houston to which he faced in Chicago, and he has taken a number of important steps to trying to resolve that disparity. And so the questions I have really relate to reading the paper and trying to understand how we might learn from it to change practices in Houston. The second paper, based on genomic medicine, was much more futuristic in its outlook, and what I attempted to do is provide a bit more context, some real-life examples of how this is implementing care in our own institution. I think we've already heard, particularly in Dr. Dever's presentation this morning, the tremendous changes that are underway in American medicine. I've outlined some of them here. I'll highlight a couple that weren't highlighted previously, and they're the top two bullets. That is the poor understanding of cancer and its causes, as well as considering issues of risk, which is inherent in all areas of intervention, including multi-level intervention, and the poor tolerance for issues of complexity or personal risk in our population. The explosions in technologies, the pace of development has been covered by others. The transitioning of the medical care system, I think, is an absolute earthquake, at least for NCI-designated cancer centers as we think of how we're going to integrate into this new system. And I think that is tremendously important because all of the research we're talking about doing is built upon academic medical centers, or at least a lot of it is. And so how that's going to shake out, I think, is going to be incredibly important. That last bullet there on the right in that section, the need to demonstrate value, is of critical importance for all cancer centers as well. We're struggling with how we're going to do that when indeed the metrics on either the quality or the cost side are not well established currently. In the Warnecke paper, again, I came at this as an eager learner. They discuss policies as they're developed at a national or state level and how they implemented them. We have to remember that policies are always a little less out of the control of certainly a research team. They're well-intended, they're hopefully evidence-based, but they usually represent some compromise between science, fiscal concerns, and political maneuvering. And so they're rarely the best that any one of those disciplines have to offer. Nevertheless, they gave a very compelling story of administration and implementation of those policies to effect change and questioning issues around access, quality, and environmental stress. I thought one of the really interesting aspects, I work more in the area of early phase drug development, and issues of signal transduction are absolutely essential within a cell. This gave clear evidence that the role of signal transduction across these levels of implementation are critical as well. And that's critical to try to link the good intentions to effective and efficient actions and ultimately improved outcomes. They wrestled with this issue of disparities in breast cancer mortality and considered at least 4 possibilities that are on most radar lists, I guess, facing a similar situation: poor or limited access to, in this case, screening mammography, poor quality of that screening when it's obtained, poor quality of treatment associated with it downstream of it, or biological differences. And their approach to this was quite elegant. First of all, it sounds as though there was an evidence base preceding this, but they convened a large number of individuals, some 102 individuals from 74 organizations, giving some idea of the scope when one attempts to undertake a multi-level intervention. Secondly, the task force worked for a period of 6 months to generate some 37 specific, pragmatic, evidence-based recommendations. I left myself wondering, though, how were these identified and agreed upon in this very complex organization? I think that's critical for progress. What were the criteria, roles, and responsibilities of the various individuals, organizations? And was this ultimately a policy-level intervention alone, or did it involve others? These are questions I had as I read through the piece and attempted to learn from it for what we might do in Houston. Next, they had a very effective strategy of taking this forward to Illinois legislators and passed really groundbreaking legislation to try to reduce disparities that involved elimination of copays and deductibles for mammography, as well as patient navigation services. However, I was again wondering whether these were all the task force recommendations, were all of them incorporated? If not, which ones were selected? How was that process managed? And then, based on the evidence that was generated and mentioned in the report, did that serve as a foundation for the action that was taken, or was it kind of concurrent at the same time, or indeed entirely independent of it? That I think would benefit at least a reader like me in trying to understand how this may relate to a situation I'm facing. And then in terms of follow-up, I was left wanting to know, took a lot of had great intentions, took a number of very important actions, which were just almost insurmountable, I would imagine, yet were achieved. But the real question is, have they impacted breast cancer mortality, their ultimate goal? If not, when will we know? How far downstream does it take to see the effects of a multi-level intervention, if indeed that's what this was? It would be interesting to know whether all of the full package was required or specific elements were particularly critical to the success of the endeavor. And I think a very important issue anytime you're affecting something as important as public policy with all of its broad implications, typically, at least in Texas, when you do something, it is typically a zero-sum game. When you do something, you give up something else. And so very important questions of how was that political and financial resources, what were the implications of focusing more on breast cancer mortality? Was anything left off that would be similarly important? I've listed some of the things of varying importance here: childhood vaccination, obesity programs in the population, down to something that would perhaps be less concerning, a public prostate cancer screening program. So I think it's very, very important to learn from examples such as this about how we think about prioritizing among opportunities. The second paper by Khoury, as I mentioned, was more futuristic in its vision. I think it's incredibly powerful and important, and Dr. Khoury and his colleagues have done a great deal to advance this field. So I was a humble reviewer. What they point out is the extremely rapid pace of discovery, the long and complex translational paths to, first of all, establish validity and efficacy, much less ever approaching effectiveness. And that ultimately, of course, we're interested in hard outcomes of real interest, which is clinical benefit. But there's a lot of investment in the T0, T1, the early phases of exploration, and relatively little in later phases. Nevertheless, those later phases are no less critical to the ultimate success that's intended. So the opportunities far exceed investments. Fundamentally, as I read this paper, it looked exceedingly familiar to me to the complex issue of biomarkers and our difficulty in advancing those. And so if we broaden the discussion now from genomics to this broader concept of biomarkers, we can see there are at least, and here I detailed 6 different ways that these are used clinically in a population of individuals. And our track record in applying biomarkers is not without at least controversy. And so I highlighted here 2 papers in prostate cancer screening using a protein-based approach, not genomic, but protein-based approach. And the disconnect that we have within our process of scientific discovery through regulatory approval and application in the public, particularly in the realm of biomarkers where the definitive proof that's required before approval is validity, reliability of the assay, rather than the overt connection to clinical benefit, different than when developing a drug. In the realm of risk biomarkers, we don't require that demonstration of clinical benefit before approval and dissemination adoption broadly in the public. And so we're left with a conundrum such as is exemplified with PSA screening, where we have some studies showing harm or at least no benefit, and others showing benefit and less harm. And we're left with a real conundrum with regard to what to do. And I fear that, that genomics is taking us in a similar path, and hopefully we'll be able to learn from history and adjust the path. Well, there are already many levels of evidence for developing biomarkers or genomic markers. So these have been codified in the literature and reasonably well adhered to. The challenge is getting anything down that stream of evidence development is extremely challenging. We also, before adoption into the clinic, have, as a body of investigators, have come up with some clearly laid out rules, intended clinical use that's delineated. The magnitude of outcomes is clear. The estimate of the magnitude is accurate, reliable, and validated. So those are done. But the fact is, in the face of desperate patients, different clinical decisions are made rather than referring back to these criterion levels of evidence. And already at Anderson, what we've seen in the last couple of years is remarkable. So these are tests, things like KRAS evaluation of colorectal cancer, but a variety of other markers that are applied in patients with the very best of intention, trying to bring the best medicine to bear on the patient sitting before you. So there's an explosion in these sorts of biomarker requests. Few of them are reimbursed, and so we're spending literally millions of dollars on these tests and hopefully improving the outcomes of some patients. Because these are used for very valid reasons, to try to improve patient selection, target identification, to match agents to diseases, as well as get better assessments of the context in which cancer is occurring. But the challenge is the evidence has not caught up, in that case, to the medical practice. Back when the TRWG was mentioned yesterday, when we led that, we identified a number of critical infrastructures that are necessary to transform our scientific discoveries into clinical advances. I'll note that few of these exist. I'll not spend any time on that. So in conclusion, with regard to the Khoury paper, one of the cases that I got out of the paper is that because of the complexity, speed, potential for misunderstanding, miscommunication, as well as the insufficient, in my view at least, regulatory oversight process that we're in at the moment, particularly applied to genomic technologies and biomarkers more broadly, and the lack of adequate preparation among practitioners, we have the very real potential, while advancing our technologies, to actually increase harms, worries, litigation, costs, and disparities, all without improving outcomes, at least uniformly. And I think this is a sobering message, but in my view at least, it's a part of the reality. I'd love to end on the hopeful note. I think there's no other way forward than to boldly move into that future. But I see a lot of challenges here, and I think the paper does a nice job of stating them, at least perhaps not emphasizing them in quite the way I would, but nevertheless bringing that reality to the fore. I think there are tremendous reasons for hope, and one of the things I think we could do is try to link, at least within government, areas that are under our control. The communication, is NCI putting forth initiatives that would answer critical questions for CMS or for FDA? Is FDA using the evidence that's created by NCI, NIH, et cetera? This implies a linearity that isn't reality. It's much more complex, of course. But at least within the realm of government, I think this is absolutely critical to model the change we're looking for in the broader field. So I'll end on a note of hope, and this is actually by Dr. Feinberg, and he stated many years ago, nature is probabilistic, information incomplete, outcomes are valued, resources limited, decisions unavoidable. So to me, it's that notion of full steam ahead, regardless of the challenges and how daunting they may appear, because there's really no path in any other direction that will be fruitful. Thank you for your attention.